Good morning, friends. I hope you can hear me. Uh, uh, if you can someone just shout out that you can?
Yes, Dr. Herwadkar, we can all hear you.
Okay, excellent. Okay, so let me just minimize this. So today we'll be looking at cranial nerves 9, 10, 11, and 12. So the last four cranial nerves in the equation here now. Uh, and these are unusual cranial nerves, interesting cranial nerves, because their outreach is far away from just the head neck area, especially the first three cranial nerves, the 9th, 10th, and 11th. The 12th, of course, the hypoglossal nerve is mainly the nerve for the uh, motor nerve for the tongue, but the 9th, 10th, 11th nerves are not just concentrated around the head area, and you'll realize the implications of the 10th nerve itself, which goes all the way down up to the pelvis. So the 9th, 10th, 11th nerve, I've lumped them together in the discussion because they have a kind of a similar course. At least part of their course is similar, where they pass through the jugular foramen. But there are some differences as well. And it's not just that similarity which occurs in that they have share a similar path before they reach their destination. But the 9th and 10th specifically also share some common nuclei, and that accounts for a similar function that is attributed to them. And you'll realize that the same nuclei subserve the function around the pharyngeal muscles, and also around the cardiac control that these two cranial nerves have. So let's start with each one of them in turn. So the first one, of course, the glossopharyngeal nerve. So as the nerve, as the name implies, it's is glosso as in tongue, so that it has to do something with the tongue, and of course there is the pharyngeal muscles that it subserves as well. So, as with any now, let's start with what is the basic embryology behind it. I'm not going to go too deep into the embryology because I think we'll run out of time at the end. But it's important to realize that it's the nerve of the third pharyngeal arch, and we have looked at the pharyngeal arches throughout our discussions, right from embryology onwards, and we have looked how the trigeminal and the facial nerve themselves were the first and the second nerve arches. So the glossopharyngeal is the third nerve arch, and vagus is the fourth nerve arch. And amongst the third arch derivatives, there are very few that are worth mentioning, but perhaps the one muscle that is important, which is relevant for our discussions today, is the stylopharyngeus, which is the muscle which is supplied by the glossopharyngeal nerve. Okay, so a very busy slide, this one. Apologies for that. But this is really the outreach, if you like, of the glossopharyngeal now. So we have got the nuclei within the lower pons, but predominantly within the medulla, and we look at these in turn. And then there are many rootlets. So you'll remember we discussed about the facial nerve, and it had many nuclei, and all of these nuclei gave rise to their individual rootlets, which combined together to form the facial nerve as we know it. Similarly, glossopharyngeal, similarly vagus, similarly the accessory and the hypoglossal nerve have small multiple rootlets. And as they come out of the brainstem, close to the jugular foramen, they will then condense together into a single nerve, and then the course outside the extracranial course subsequently gives rise to the various nerves as we know about. So, depending upon the function that it subserves, if you have got the different nerve fibers and the different nuclei. Okay, so what are the different ones that we know about? So we have got the efferent fibers, efferent as in the motor, and then we have got the afferent fibers as in the sensory fibers. So what are the efferent fibers? Well, the efferent fibers, we have got the special efferent motor control. And as I said, the main one that it does is the stylopharyngeus muscle. And the stylopharyngeus is a very critical muscle because it elevates the larynx and the pharynx, especially when we are speaking or swallowing. So very crucial muscle, and hence when there is a glossopharyngeal palsy, which usually does not occur in isolation, because a, it shares the common nuclei with the 10th nerve, b, it shares the common path, and c, it also shares common ganglion along with it, along with the 9th, 10th. So quite often these two nerves are affected in unison, if you like. But if you do have 9th or 10th or 9th and 10th palsy, is going to affect these swallowing mechanism, the speech mechanism, giving the different tone to the voice, and of course causing various forms of swallowing difficulties. Then we come to the visceral, general visceral efferent, okay, and these are the parasympathetic outflow. So we have again looked at the third nerve with its parasympathetic outflow through the Edinger-Westphal nucleus. We have looked at the parasympathetic outflow of the facial nerve, the superior salivatory nucleus, and the lacrimatory nucleus, which gave rise to the innervation to the lacrimal glands through the greater superficial petrosal nerve, but also the inferior salivary glands. Similarly, the glossopharyngeal nerve has a parasympathetic outflow, and this parasympathetic outflow comes off through the brainstem, joins via these multiple rootlets, and then it sends a branch which goes into the tympanic cavity, which is called as a tympanic branch, and there along the tympanic plexus it comes out along with the greater superficial petrosal nerve. Remember, this is the branch which comes from the vagus, but then it comes out, comes down, and follows the otic ganglion, which you'll remember was belonged actually to the trigeminal nerve, and then hitches a right along with the auriculotemporal nerve to supply the parotid gland. So this is the parasympathetic outflow. Again, very, very important, because diseases of the parotid gland can spread along the auriculotemporal nerve, and also important to remember that any diseases within the tympanic cavity or along this tympanic branch can reduce the outflow from the parotid gland, especially if it is bilateral. What are the efferent ones? Again, we don't see these efferent fibers, but extremely important for homeostasis because they regulate the carotid sinus and the carotid body. So we have got afferent fibers which come along the glossopharyngeal nerve and takes the information back into the brainstem. And hence is so much vital for the baroreceptors. And finally, the somatic efferent, which is basically sensation of touch and and tension from the oropharyngeal and the buccopharyngeal airways, the muscles. Um, but also important to remember finally is that the glossopharyngeal is the afferent, not just any afferent, but a special afferent for the posterior third of the tongue. We have seen the chorda tympani last week, which was for the anterior two-thirds, but for the posterior third, it's the special gustatory nerve which takes the sensations back to the brainstem. So these are the nuclei here that we have, which will do these functions. So you have got a nucleus ambiguous. This is the motor nucleus which supplies the stylopharyngeal, which is the muscle we talked about. This nucleus ambiguous, it also shares the same nucleus with the vagus nucleus. So we'll come back to this again in discussions of the vagus. Then we have got the inferior salivatory nucleus, which is the same nucleus which is in continuity with the superior salivatory nucleus, which is the same nucleus which is in continuation with the lacrimal nucleus of the facial nerve. So these are the uh, parasympathetic outflows from the facial. Of course, they will go to the lacrimal gland and the submandibular glands, but from the glossopharyngeal, they're going to go to the parotid gland, which we just reviewed earlier on. And then the other things that it shares is these dorsal nucleus of the vagus and the nucleus of the tractus solitarius. The nucleus of the tractus solitarius is nothing but the nucleus which controls the which has cell bodies which detect the sensation from our tongue, not any sensation but special sensation which will detect the various taste from the tongue. So this is the same nucleus the glossopharyngeal is going to share with the facial with the chorda tympani of the facial, and also with the vagus nerve. And then we have got the dorsal nucleus of the vagus, which gives off fibers which will detect the baroreceptors along the carotid sinus, but will also control some of the cardiac fibers. So again, this is a common shared nucleus. And finally, this is the long nucleus of the spinal of the trigeminal nerve, and we have looked at the trigeminal nerve, and you'll realize that the trigeminal nerve not only uh, 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 innervates into this spinal nucleus, but you'll get innervation from the glossopharyngeal nerve. You'll get innervation into it from the vagus nerve. So it's a common nucleus. It's a long nucleus. These are long nuclei which are shared by these cranial nerves. Uh, And just look at the arrangement again. The motor nuclei are more medial, more anterior, and the sensory nuclei are much more posterior, much more lateral. And you'll remember our discussions on embryology where the sensory nuclei are lateral, the motor nuclei are much more medial. And this is just to show you the diagrammatic representation of how these various cranial nerve nuclei are eventually going to control the various functions that they subserve. So this is what we have looked at. Just to recap again, we have got the special sensation coming from the posterior aspect of the tongue, the nucleus solitarius, which is around here. Then we have got a dorsal motor nucleus, which is again, sorry, it should not be motor, it's a dorsal vagal nucleus. It's a sensory one controlling the carotid sinus. The inferior salivatory nucleus, which is a parasympathetic outflow, again in continuity with the superior salivatory and the lacrimal nucleus. The nucleus ambiguous, which is this one here, which is the motor nucleus to the stylopharyngeus, which is in continuity with the vagus nucleus as well. And finally the trigeminal nucleus of the spinal component of the trigeminal nucleus, which we have heard, which we know goes down almost up to C1 C2 level. And this will give the convey the sensation of pain and temperature from the tongue, but also from the pharynx as well. So this is about the nuclei. And where are they located? So this is where they are located. If you look at this specimen over here, and this is an axial T2 sequence, very high, is a very zoomed in, magnified area to demonstrate the nuclei. And this is where they are. So just to sort of recap the anatomy around this area, this is the medulla over here. This is the fourth ventricle. This is the inferior cerebellar hemisphere. So you have got the choroidal a fissure which comes out through the foramen of Luschka. This is the foramen of Magenti with a small branch of the pica over here. So this is the fourth ventricle. This is the floor of the fourth ventricle. This is the roof. So we are posterior here, anterior here. This is right, this is left. In front of the brainstem, you have got the confluence of the vertebrobasilar artery. Here, this is the vertebrobasilar confluence, proximal basilar artery, and you have got the branches from these arteries over here, which are going to supply. So the nuclei are located in the posterior aspect over here, and this part over here of the posterolateral medulla is called as a restiform body, which is also part of the inferior cerebellar peduncle. Again, we have discussed this when we've talked about the morphology of the brainstem, which basically conveys fibers from the brainstem towards the cerebellum itself. So these is where these nuclei are congregated. So this is a common nucleus of the ninth and 10th nerve, the four nuclei which we have looked at. So from this nuclei, the nerves are going to go out. Again, this is an axial T2 sequence. Again, I want to re-emphasize this anatomy because this is crucial in our understanding of the anatomy of the ninth and 10th nerve. Look at the fourth nucleus, identify the foramen of Luschka laterally, identify the foramen of Magenti in the midline, posterolateral aspect, which is like almost a quadrilateral shape. This is the inferior cerebellar peduncle with the content restiform body, and the nuclei are located in that location. And you can just about see the nerve coming out from this location over here. And this is on a CT scan. Again, just to try and understand where these are on a CT scan, this is where the vertebrobasilar confluence is. This hyperdensity is basically the choroid plexus. This is the flocculus of the cerebellum. So this is the fourth ventricle. This is the foramen of Luschka. So this is where the 9th, 10th nerve nucleus complex will be located. And these are just some examples where they can be affected. You will have recognized this area of high signal over here on T2, high signal on flare sequences. To different patients over here, posterolateral medulla involvement. This is nothing but Wallenberg syndrome, which can affect swallowing and speech amongst various others problems that they can have. But you can see in this same patient over here, it doesn't just affect the brainstem because it is a pica artery, it also affects the cerebellum. So posterior inferior cerebellar artery is not just a cerebellar artery, but it is also supplies the brainstem. And I'm sure we will discuss this in much more greater detail when we look at the vascular anatomy of the brain. But this is where the infarction within the posterolateral medulla is going to affect our 9th, 10th nerve nuclear complex. Okay, so let's move out now from the brainstem. Now it has to go through the cistern. What it does is it comes out from the brainstem, from this conglomerate area, and goes out into the lower cerebellopontine angle cistern. And it's a very specific area it comes out from, and this is where I would like you to concentrate on this area here anteriorly. And we have looked at this in the past, and this is just a micrograph of the same area. You can see this is the midline over here, the midline sulcus. This is the fourth ventricle at the back end. On either side of the midline are the pyramidal tracts or corticospinal tracts. Remember, these are not yet decussated. Then there is a lateral bulge, and this is caused by a very large nucleus which is called as the inferior olivary nucleus. There is also superior olivary nucleus, which is more higher up, of course, in and more in relation to the lower pons. But this is the inferior olivary nucleus, and there is a sulcus in between the olive and pyramid. And there is another sulcus behind the behind the olive, and the glossopharyngeal nerve, the 10th nerve, comes out just behind this olivary sulcus. So this is the pyramid over here in the midline on the MR scan. This is the midline sulcus, and you can see the bulge produced by the olive, and the glossopharyngeal nerve complex is going to come out in this sulcus, which is behind the olive, and traverse towards the cerebellopontine angle towards the jugular foramen. So this is the cisternal course, if you like, of the glossopharyngeal nerve. And these are high resolution T2 sequences just to demonstrate that same anatomy over here. You have got the confluence of the vertebrobasilar arteries there. These are the pyramids, the midline sulcus, the sulcus between the pyramid and the olive, which we'll look at when we discuss the hypoglossal nerve. And then this is the sulcus behind the inferior olivary nucleus, and that's where you would locate the glossopharyngeal nerve. Quite often you see small branches, and these typically are branches of the posterior inferior cerebellar artery, which is a branch of the vertebral artery, which typically takes a course in the premedullary, in the lateral medullary portion, and then in the retromedullary. And along its way, it's going to give off all the branches to the brainstem, typically the medulla, as it goes, enters the foramen of Luschka before doing its other business with the cerebellum. So these are the branches that you often see, and then along its way, it then reaches the jugular foramen. Uh, and this is just to show you that very much like the trigeminal nerve, very much like the facial nerve, these vessels can sometimes impinge upon the glossopharyngeal nerve. Unfortunately, we see these vessels quite often, and hence the clinical correlate is very, very essential. But in this patient, certainly the glossopharyngeal nerve is clearly indented on its way by a very tortuous pica artery over here. And this is the concept really to talk about the transition zone when we discuss about glossopharyngeal or, for example, trigeminal or seventh nerve neuralgia. And this is basically concept where it's a histological concept. There is no radiological correlate to it apart from a distance from the brainstem, which is usually within a few millimeters of the exit point from the brainstem. But the histological correlate really is where the myelin, the central myelin, which is oligodendrocyte derived, changes over into the more peripheral myelin, which is derived from the Schwann cells. And that makes this zone, this transition zone, much more susceptible to indentation and compression from the vessels, and hence the effects of it resulting in neuralgia. Okay, so we have come out of the cisterns now. Now we are approaching the jugular foramen. So jugular foramen is a foramen within the skull base. It's a unique foramen which is located between the occipital bone more medially and the petrous bone laterally, and it's got a very interesting anatomy around it. And I want to just share the next few slides talking about the anatomy of this jugular foramen, because of course it is jugular foramen because it contains the internal jugular vein. So it's important to understand the venous anatomy. But just to look at it before we go into the venous anatomy, just anterior to that is the internal carotid artery canal. So this is the carotid canal within the petrous bone, which lies anterior and medial to the much more dilated, much more prominent jugular foramen, which is posterolateral. This is on a CT scan, and this is a CT venogram to show you the venous anatomy. So this is the torcula with the left transverse sinus, the right transverse sinus as it goes along, and the transverse sinuses just behind the mastoid air cells are going to swing forward to become the sigmoid sinus and then converge into the jugular foramen, which is the structure that we see here. And this is on the sagittal view over there. And this is just to show you the same anatomy on the MR scan. These are the glossopharyngeal nerves extending towards the petrous bone. This small area over here is actually the cochlear aqueduct. We were talking about the cochlear aqueduct and the cochlear duct last week. The cochlear duct is located within the cochlea itself, while the cochlear aqueduct is actually a channel within the petrous bone itself. But the glossopharyngeal nerve enters the jugular foramen, which is just below the level of this cochlear aqueduct, which is over here. And this is the appearance of the post-contrast MR scan of a patient with enhancement because of presence of flowing blood. And this is just to show you the discuss the anatomy in a specimen over here, the jugular vein, the carotid artery, the internal carotid artery anteriorly. There are other structures that we need to identify, and what we do have here anteriorly is the inferior petrosal sinus, and it's a sinus which drains more anterior aspect from the clivus, but also drains sometimes the brainstem, and it is located in this location, just anterior to the jugular vein and medial to it, around about this location over here. This is a post-contrast CT scan. This is the carotid artery. This is the jugular vein, and you can see the inferior petrosal sinus draining towards it. Just to recap again, on the CT scan, you have got the jugular foramen over here, the internal carotid artery within the carotid canal, and they are separated by a very small spicule of bone, which is the jugular spine. Which you can see over there. And this jugular spine is interesting because what it does is not only separates the carotid canal from the jugular bulb, but also divides the jugular foramen into a smaller anterior and a larger posterior compartment, what we call as a pars nervosa and a pars vascularis. The vascularis, of course, contains mainly the veins over there, and the pars nervosa contains principally the ninth nerve. The 10th and 11th nerve are located more posteriorly. This is much more high resolution sequences now, post contrast, the fiesta sequence in the axial plane, and this is kind of more of an oblique coronal plane to show you the same anatomy. So here we are. Again, the anatomy is the same. We have got the medulla, we've got the cerebellum, the cerebellopontine angle systems, the vertebral artery over here, the branches of the pica in there, and we have got the sigmoid sinus, which turns into the jugular bulb in the jugular foramen. The carotid artery, number one, is the carotid artery, and then we have the inferior petrosal sinus, which drains into the jugular vein. The small arrow over here anteriorly is where the ninth nerve is going to lie, and the more posteriorly we get the 10th and the 11th nerves within the canal. And if you do an oblique reformat, you can see that the ninth nerve is right at the top, and the 10th and the 11th nerves are at the bottom end. So these 9th, 10th, 11th nerves share this common root in the jugular foramen, but the 10th and the 11th nerve are slightly more inferior and slightly more posterior within the jugular foramen. And this is just again to show the what it looks like. So here, this cerebellum, the flocculus of the cerebellum, you have got the pyramid, the olive, the retro olivary sulcus. You'll remember this is where the nerve comes out and goes into the jugular foramen. This is the jugular vein, which is formed from the sigmoid sinus. They all converge together in this jugular foramen, with the nerve located more anteriorly, with the vein located more posteriorly. And this is a much more high resolution sequence here. The internal jugular vein, the carotid artery in the front, and the jugular spine, which separates the pars nervosa, which is more anteriorly, from the more posterior pars lateralis, which contains the 10th and the 11th nerve. So the 9th nerve is much more anteriorly located there. And these are very difficult to see on standard images. These are 3 Tesla images, and these are post-contrast fiesta 3 Tesla images. Hopefully, once we have our 3T running up, we should be able to generate some similar images. And again, some magnified views of the same to demonstrate. So this is our seventh nerve. This is the coronal section. So this is the you have spotted the internal auditory canal, the seventh and the eighth nerve, with the cochlea, vestibule, and the semicircular canals there, the middle ear cavity, and then these are the ninth and the tenth nerves, which then go through the jugular foramen on their way down towards the neck. And these are the same appearances. We have got the seventh, eighth nerve. This is a patient with a vestibular schwannoma within the internal auditory canal, and these are the rootlets of the 9th, 10th, and the 11th nerve as they traverse into the jugular foramen. And just to highlight some of the diseases over here, this is a patient with a nasopharyngeal carcinoma, it's in trying to show you the diseases, I also want to show you the importance of some of the sequences. And this is a T1 weighted sequence, and it's a T1 weighted sequence is very, very extremely useful, especially at the skull base, because wherever there is fat, you will see it as a bright area. Especially you can see here within the midline bone, the clivus, you can see the uh, hyper intense marrow, which is normal marrow because it contains fat. But this tumor over here within the roof of the nasopharynx has infiltrated into the clivus, replacing it. So this is direct extension into the clivus, but you can see there is much more lateral extension towards the jugular foramen. Again, here on the same patient, you can see this is a cancer within the nasopharynx. Same patient, it's more difficult to appreciate what's happening within the clivus. It's much more easier to appreciate what's happening within the clivus on this T1 sequence. This is a T2 sequence. We have saturated the fat. So this is a T2 sequence with fat sat or a stir sequence. And you can see how the disease has spread much more laterally towards the jugular foramen, towards the area of the carotid sheath. Uh, Other pathologies, of course, the ubiquitous meningioma over here, you can see it's involving the intracranial aspect, the lower cerebropontine angle cistern, but it has extended outside to involve the carotid sheath as such. Another patient with another tumor, I've shown you a vascular picture that will aid in the diagnosis. These are very, very vascular tumors. So this is a paraganglioma of the which occurs in the jugular foramen. So you can see the thrombosed appearances. So this is the normal appearances of the sigmoid sinus with low signal on T2 weighted sequences, and this converges into the sigmoid sinus into the jugular bulb over here. Whilst here there is tumor within the jugular bulb which has invaded and thrombosed the sigmoid sinus, and these are extremely vascular tumors which need preoperative treatment before surgical resection. So we have now looked at the nuclear component, we have looked at the cisternal component, we have looked at the jugular foramen. Now we are going to go out of the jugular foramen into the extracranial course, and this is where it becomes very, very difficult to appreciate on us imaging. So most of the cranial nerves, we will not be able to see them once they have exited uh, out of the, especially the branches, once they've exited out of the skull base. These are the branches that they send off. So we have talked about the superior inferior ganglia, which are sort of focal bulges over here on the glossopharyngeal nerve. It is very difficult to see these ganglia. They are located on either side of the jugular foramen. Uh, Outside the skull, it accompanies the carotid artery. So it's very important to locate the carotid sheath. So the carotid sheath concept is extremely important when you're looking at the anatomy of the 9th, 10th, 11th, and 12th now. And the carotid, the nerve itself lies just anteromedial to the carotid artery, round about this plane. And from here, it will supply the fibers to the stylopharyngeus. Remember the stylopharyngeus muscle we talked about, which elevates the palate and stops the regurgitation of food and is so important in our speech. It sends sensory fibers to the carotid sinus, so the fibers will descend along the internal carotid artery and supply the carotid sinus, the sensory fibers. It will also supply a lot of fibers to the muscles around the pharynx, the constrictor muscles. It will obviously end up supplying the posterior third of the tongue. So these are kind of the branches, if you like, of the nerve as it comes out from the neck. And most of these branches are not visible on MR imaging. And this is just again a quick recap of what the supplies of these nerves. We have looked at the superior inferior ganglion, which are located on either side of the of the jugular foramen, and then from the inferior ganglion, the tympanic nerve, which supplies the parotid gland by using the auriculotemporal branch of the mandibular nerve, and then the branches which will go to supply the uh, stylopharyngeus muscle, the branches which will supply the posterior third of the tongue, and the branches which will supply the carotid sinus and the carotid body. But one nerve which is worth mentioning is the auriculotemporal nerve. So just to recap the anatomy over here, this is a CT scan, very much zoomed in. Remember, our friend is going to be the carotid sheath. This is the pharynx over here, the carotid artery, the vein. The, the glossopharyngeal nerve is going to be located in this area over here, and it has to supply the parotid gland which lies superficially over there. And what it does is it sends off the branch, the parasympathetic outflow, which goes along with the branch, auriculotemporal branch of the mandibular nerve. The mandibular nerve, we have looked at the third division of the trigeminal nerve. It sends off this auriculotemporal branch, which surrounds the middle meningeal artery, goes behind the ramus of the mandible over there, behind the mandible, and then supplies the parotid gland, the secretomotor fibers. And this is the patient. Just to look at the anatomy over here, the mandible, the muscles of mastication over there. This is the pharynx. These are the muscles of the pharynx. The carotid sheath is over here, the internal carotid artery, the jugular vein, the auriculotemporal nerve, and you see it not uncommonly in that location, especially if the person has a fair amount of fat, which is useful because the nerve on this T1 sequence can be highlighted as a dark structure located in this retromandibular location, coursing towards the parotid gland. And this is a patient who had previously had a tumor, and you can see this thick nodular recurrence of tumor, which is now along the auriculotemporal nerve, the perineural invasion of this nerve. So even though we cannot see the nerve branches itself, certainly we can see the effects of this nerve on imaging. If a patient has a facial palsy, of course, we will know the patient has a facial palsy when we inspect the patient by the paresis on the face. But if the patient has a glossopharyngeal palsy, we can listen to them. Their speech is different. We can ask them their swallowing problems. And this is just to show you how the muscles are seen on when the patient has got a 9/10 nerve palsy. So this is a coronal T1 sequence, brainstem over here. This is the internal auditory canal. These are the cochlea and vestibule. This is the odontoid process. So this is C2, this is C1, this is the occipital condyle. Just lateral to the occipital condyle, you will find the jugular bulb over there along with the hypoglossal canal, which we'll come to later on. But this is a patient over here, extensive destructive process involving the hypoglossal canal, but also involving the jugular foramen and the glossopharyngeal 9/10 nerve complex. And what that has led to is denervation of the muscles. And you can see the atrophy within the stylopharyngeus. You can see the absence of muscle. This is the normal muscle. You can see what is happening over here. This is the normal constrictor muscles of the pharynx, and you can see the degree of atrophy, which has led to the uvula prolapsing down into the oropharynx. And this is the same patient. Remember, he also has hypoglossal palsy, and you can see what has happened to the tongue. This is a T1 weighted sequence. There is fatty atrophy within the tongue, which is now prolapsing back, giving rise to this appearance. So we can see the effects of this on a scan, even though we cannot identify the nerve fibers themselves. So that was a tour through the ninth nerve. So let's now move on to the 10th nerve, the vagus nerve. As I said earlier on, the vagus nerve shares many things with the ninth nerve. It shares a common passage through the jugular foramen, but it also shares, as I've discussed with you, the some of the nuclei. So what is vagus? So vagus is wandering or straying, and it really wanders all the way from the skull base all the way into the abdominal pelvic viscera. So a vagabond nerve, if you like, hence the vagus terminology. And it innervates very vital structures along its way. Of course, it is the longest cranial nerve. If it has to start from there and has to end up here, it's a very long nerve. It contains both motor and sensory functions, and as a, it controls a lot of vital visceral functions. It's a fourth arch derivative, and because it's a fourth arch derivative, it's going to be controlling mainly the muscles of larynx and pharynx. So what are the various nuclei? this is exactly the same slide as I had for the glossopharyngeal now. So it will have the same nuclei, the nucleus ambiguous, which is a muscles, which controls the muscles. Of course, the muscle that it controls is different. We had stylopharyngeus, which was controlled by the glossopharyngeal, but here we have got a lot of more muscles which are now under control by the vagus nerves of the pharynx and of the palate. The dorsal vagus nucleus control the carotid sinus via the glossopharyngeal, but via the vagus it's going to control the cardiac muscle itself, but also the smooth muscles of the trachea and the digestive tract. We have got the solitary nucleus, which you'll remember was a nucleus which was taking taste sensation back from the posterior third of the tongue. Similarly, we have got some sensations which can go via the vagus nerve from the pharyngeal area, but also it will carry some of the general visceral afferent or from these areas around the epiglottis and palate. And finally, the sensory nucleus of the trigeminal nerve, which is a long nucleus from pons to C2. And not just a trigeminal nerve, we have looked at this, but also the glossopharyngeal nerve and the vagus nerve will relay into it. And the vagus typically will carry sensations from the auricle, from the external auditory canal, and the dura of the posterior matter for posterior cranial fossa. And there are some clinical examples where vigorous irrigation or vigorous scratching of the external auditory canal can actually cause cardiac dysfunction in some of this some patients, which tells us that it is the stimulation of the vagus nerve which has led to that. So the location of the nucleus again very similar to because it's the same nucleus. They are located in the posterolateral medulla over here. The anatomy we discussed in the glossopharyngeal nerve nucleus because it's similar nuclei which are located in that aspect within the floor of the fourth ventricle, just medial to the foramen of Luschka, and these cranial nerve nuclei give out the vagus nerve at a level just slightly below the ninth nerve. This is a patient who has got Horner syndrome, has got Wallenberg syndrome, along with involvement of the ninth and tenth nerve complex. And this is sort of a coronal slice, if you like. So the ninth nerve is right at the top end, the 10th nerve below, and the 11th nerve, which comes off most inferiorly as they converge towards the jugular foramen uh, on their way outside the skull. So this is the cisternal portion of the vagus nerve as it's going to enter the jugular foramen. This is the carotid artery here in the front, and this is the sigmoid sinus and just part of the jugular bulb that before it forms a jugular vein. Uh, the visceral supply of the vagus nerve is really uh, beyond discussion for this topic. So I think we'll have to leave it as such. But it's important to recognize this the importance, even though we cannot identify them on scans. Uh, so in the neck, we have got the carotid sheath, and we'll look at that. We have looked at that. It enters the thorax anterior to the subclavian on the left side, and between the subclavian and the common carotid artery on the right side. In the mediastinum, it's going to give these branches to the lungs and to the esophagus, and as it enters the abdomen, it's going to go along with the esophagus through the diaphragmatic hiatus. The left side is anterior and the right side posterior. Those of you who know the embryology of the development of the stomach will know why this happens. That's because of the gut rotation. Finally, it will supply the efferent fibers to the abdominal viscera, so the parasympathetic outflow. So that's kind of the visceral outflow. Um, for sake of discussion of the neurological anatomy, we'll just look at some of the anatomy within the neck. And again, our friend here is going to be the carotid sheath with its internal carotid artery anteromedially, the jugular vein posterolaterally, and the nerve itself lies within the carotid sheath. And over here, it is prone to diseases within the carotid body. For example, over here, this patient who has got a paraganglioma. This is from my previous life when I used to do neurovascular intervention. This is a patient with a paraganglioma, extremely vascular, and not only at the skull base, but to show you that paragangliomas can occur even at the carotid uh, bifurcation. So this is a carotid body tumor, which is vascular. Uh, So the neck branches, because we are looking at the neck, the branches that are relevant for discussion are the pharyngeal branches, the laryngeal branches, and the cardiac branches. And of course, we don't see these branches, but we can understand the effects of them in when they are impaired, of which one is worth mentioning is the recurrent laryngeal branch. The superior laryngeal nerve, sorry, if I just go back, the superior laryngeal nerve is basically a nerve which supplies the larynx and the pharynx, mainly the muscles outside. But the recurrent laryngeal nerve is the one which controls the vocal cords. The superior cardiac nerve is again not seen, but it's important to realize that it is given off in the neck, and the importance is twofold in that any damage to the nerve within the neck can give rise to tachyarrhythmias, and b it's this is where uh, the vagus nerve is targeted for stimulation for various epilepsies. So the recurrent laryngeal nerve, as I said, is worth mentioning because it has a very unusual course, and the unusual course is that it goes all the way down into the mediastinum. On the right side, it hooks the subclavian artery and then ascends back and supplies the cricoarytenoid muscle, which is the muscle of larynx. And on the left side, it has to take much longer course because it has to go in underneath the arch of aorta as it hooks back up, and this makes it more prone to diseases in the superior mediastinum. Like in this patient over here, you can see the diseases within the aortopulmonary bay, as it is called. As this is a patient with a tumor over here, and that has resulted in vocal cord palsy. So this is a vocal cord which is much more medial, this is a vocal cord which is much more lateral, which is how it should be. So this is the larynx which has been affected, the vocal fold which has been denervated because of disease of the recurrent laryngeal nerve, which is a branch of the vagus given off within the neck. So final two cranial nerves, we have got the 11th and the 12th cranial nerve, of which the 11th cranial nerve is the one which we uh, which is extremely difficult to appreciate because the fibers are many and small, and we almost never see it as an individual nerve because there are so many rootlets to it. It of course is the nerve which subserves the sternocleidomastoid and the trapezius muscle. But it's a very interesting now. It not only does that, it also gives rise to some fibers which join up with the vagus nerve. And because it joins up with the vagus nerve, it has to share a common nucleus. And the nucleus it shares is the nucleus ambiguous. So the nucleus ambiguous shares, you'll realize from the facial now, it was a nucleus which went along with the chorda tympani to the which supplied the muscles within the middle ear cavity. Similarly, the same muscle supplies was used by the glossopharyngeal nerve for the stylopharynges. Same muscle was used by vagus nerve for the constrictors, and the same is also used by the accessory nerve because it does supply is some of the pharyngeal constrictor muscles. So this is the cranial component. So it has got two components. It's got a cranial component. This is the vagus, and this is the cranial component of the accessory nerve. So the inferior part of the nucleus ambiguous is called as the accessory nucleus ambiguous, but it's basically in continuity with the main nucleus ambiguous, and the fibers from that join up with the vagus nerve to supply the muscles of the larynx and the pharynx. But it is this spinal component uh, uh, of the accessory nerve which comes off from the spinal cord. From the anterior aspect, the nuclei, then the rootlets will come off from the lateral aspect, and then they ascend up the spinal canal, which is very unusual, go through the foramen magnum, and then join the intracranial or the cranial part of the accessory nerve. So the spinal and the cranial join together again at the level of the jugular foramen, and then this fiber descend down again and supply the sternocleidomastoid and the trapezius muscle. So it's a very unusual course that this now has. And this is just to highlight again the same findings. So this is a spinal cord, this is the medulla over here, the spinal nerves as it come as the cervical nerves as they come out towards the brachial plexus. But some of these rootlets will join up together, sometimes as low as C7, and then ascend through the foramen magnum, and then join the vagus, join with the cranial component of the accessory nerve, and descend down to supply the trapezius and the sternocleidomastoid. We cannot really identify this now separately within the jugular foramen, but it's again too important to remember that they are located more posteriorly as compared to the jugular to the glossopharyngeal nerve, which is located more anteriorly. But of course, we see the effects of the nerve, and this is the nerve damage, and this is a patient who's had previous radical neck dissection. Over here, you can see the significant atrophy on the left side of the neck. We've got the carotid sheath with the jugular vein laterally, the carotid artery, the thyroid gland, the trachea there, the vertebral body over here, and you can see the significant atrophy. The carotid artery has been, the jugular vein has been dissected out, but there is atrophy of the muscles which are supplied by the accessory nerve. So you've got a trapezius over here, and you can see that the trapezius is significantly atrophied on this side. And this is a different patient. Again, you can see the atrophy of the sternocleidomastoid muscle. This is a normal sternocleidomastoid muscle here, with the carotid sheath lying deep to it. This is the carotid sheath lying deep to it with the jugular vein and the carotid artery, and you can see the atrophy that has occurred within the sternocleidomastoid muscle. So even though we cannot see the muscles themselves, we can see the effects of damage to that now with atrophy within the muscles. Here is the same patient with atrophy of the trapezius muscle. So we can see the denervation changes that can occur in the muscles. Okay, our final nerve for discussion today is the hypoglossal nerve. Okay, so the hypoglossal nerve, it's the somatic nerve, efferent. It's mainly efferent nerve, and its principal job is to innervate the muscles of the tongue to allow mastication and speech function, which it subserves. And it's very much like the ventral roots of the spinal nerve. So when we looked at this, when we looked at the basic anatomy of the spinal cord, and we'll do this again when we discuss the spinal cord anatomy, we have got the ventral root and the dorsal root. The ventral roots are the motor roots, and this is what they are. It's very much homologous to the ventral roots of the spinal nerves. Uh, it has we didn't really discuss the supratentorial control of the vagus, the glossopharyngeal nerve, because these are multiple areas that the control is derived from. But for the hypoglossal nerve, you know that the tongue is represented on this homunculus on a very special area, which is on the inferior frontal lobule, very close to the operculum of the frontal lobe, adjacent to the sylvian fissure over here. So this is the area which we are looking at, and the corticobulbar tracts, which are the fibers which will control the nuclei of the hypoglossal nerve. This corticonuclear corticobulbar tracts will cross each other, and the supply actually is bilateral. So unilateral frontal lobe infarcts is very unlikely to cause any damage to the functioning of the tongue. So you'll need bilateral involvement, but typically the involvement occurs at the level of brainstem or within the hypoglossal canal to cause denervation of the tongue muscles. So you'll be bored by this diagram now. I've shown it many times now throughout the course of these discussions, but it's very essential to remember this anatomy is so much based on our embryology. So this is the neural tube over here, the alar plate, and the basal plate. The LR plate, which is going to give rise to the sensory neurons, the basal plate, which is going to give rise to the motor neurons. The motor neurons are more ventral, the motor neurons are more medial as compared to the more sensory neurons, which are derived from this LR plate, which are more lateral and posterior. And hence, the hypoglossal nucleus, which is more medial, which is more anterior, is a motor nucleus, and that's the location. So if you are got to hunt for the hypoglossal nucleus, this is where we're going to go and search for it. So this is we are going to search for it right in the midline, in the paramedian location. It's much more posterior. This is a lateral view, fourth ventricle over there, the cerebellum, and you can see the location of the hypoglossal nerve nucleus, which is very dorsal, very medial, which is very much similar to the anatomy within the spinal cord as well. So this is what it looks like on an axial T2 sequence if you have got to hunt for it. So this is very close to the foramen magnum level, not quite. You can still see the bulge produced by the pyramid over here. This is a zoomed up picture, the bulge produced by the pyramid, and this is where the hypoglossal nerve nuclei are, very close to the midline, very close to the dorsal aspect of the medulla oblongata. Now you can see over here we are actually at the level of the vertebral arteries. Previously we were higher up talking at the vertebrobacillar confluence, but here we are at the level of the vertebral arteries, and these are the hypoglossal canals. Um, so this is more diagrammatic representation over here. This is the hypoglossal nucleus that you can see. dorsal aspect of the medulla, and we can see the other nuclei. The nerve then has to take a very long course anteriorly, and then it comes out of the brainstem just behind the pyramids. You can see this is the medial lemniscus. We have talked about the medial lemnisci in the past when we looked at the various tracts within the brainstem. Just to recap, these are formed by the fasciculus cuneatus and the gracilis, which are the dorsal cord fasciculi, which come up and then cross to form the medial lemnisci. So they are going to take very special sensations like fine touch from the opposite side of the and pinprick and tactile localization from the other half of the body. So they are going to lie in between this medial lemniscus and the inferior olivary nucleus. That's the trajectory, and then they're going to swing laterally to come behind the pyramidal, between the pyramid and between the inferior olive. So this is again the same anatomy over here. This is the 12th nerve as it traverses anteriorly and then swings laterally, uh, uh, and as it comes out, you can locate it by using the vertebral artery as a reference, because it is typically located behind the vertebral artery. And this is a patient with infarction. You can see that the pyramid is involved over here. The pyramid is involved, but not only the pyramid, there will be involvement of the medial lemniscus. So the patient will have contralateral hemianesthesia, contralateral hemiplegia, but also will have ipsilateral hypoglossal palsy. And this is a diffusion weighted image of the same patient. And this is just to remind us about the pathways in that location. So you've got the 12th nerve over there, the medial longitudinal fasciculus, the olive, and the pyramidal tracts anteriorly. So the pyramidal tracts, of course, will result in weakness in if there is involvement of the pyramidal tracts, and involvement of the tongue uh, uh, by infarction, resulting in deviation of the tongue towards the site of the palsy, and that swallowing, which typically is a result of course, infarction within the tongue, but also involvements of the ninth and the 10th nerve. The dizziness and the ataxia is involvement of the inferior cerebellopeduncle, and also some of the lower cochlear and the vestibular nerves. uh, uh, just to again look at this anatomy on the high resolution MR scan, we have looked at this, but I just want to revise this before we move on to the next slide over. This is the midline. This is a high resolution of the medulla itself, midline sulcus, the pyramid, the olive, the sulcus in between the pyramid and the olive, the retroolivary sulcus. We have looked at this. This is where the glossopharyngeal, the 10th nerve, the 11th nerve are going to come out from. This is the inferior cerebellopeduncle. This is where the 9th, 10th nerve nuclei are. The hypoglossal nucleus is located in this area over here. And it typically produces a very small bulge as well along the floor of the fourth ventricle, very similar to the facial colliculus. We can call this as a hypoglossal colliculus. And it exits out. When it exits out ventrally, and in multiple fibers, and these converge towards the hypoglossal canal, and these fibers come out, as I said, between the pyramid and the olive, as compared to the previous one which came out behind the olive. The 9th, 10th nerve fibers come out behind the olive. This one comes in front of the olive, and they lead towards the hypoglossal canal. So let's look at the hypoglossal canal, also called as the anterior condylar canal. Easier to appreciate on an axial CT scan. It is located within the occipital bone, entirely surrounded by the occipital bone. Over here, you can see this is the lower end of the clivus, and this is part of the occipital lateral ex-occipital bone, and this is the canal. So the nerve is going to traverse through this area over here. Um, and this is high resolution T2. We have got a jugular foramen over here. The anterior condylar canal, or the hypoglossal canal, is much more anterior and at a slightly lower level as compared to the jugular bulb. And this is what, again, to show you the CT scan over here. This is just a pictorial representation of the canal, and this is where it is located. This is the jugular bulb, and this is the anterior condylar canal, or the hypoglossal canal. And just to show you a embryological variant, hypoglossal artery, it's a persistent hypoglossal artery, very rare variant. It basically communicates the vertebral artery with the internal carotid artery, not a common variant at all. And on the coronal view on the CT scan, um, uh, uh, it's got this special appearance called as the eagle hook, eagle beak appearance. Uh, just to kind of revise the anatomy over here, these are the mastoid air cells. This is part of the petrous bone. This is the jugular foramen with the 9th, 10th, 11th nerves, and this over here is the hypoglossal canal, and this is supposed to show this beak of the eagle, which is here, and just underneath that beak around here, this is where the hypoglossal canal is located. So if you are suspecting someone with a hypoglossal nerve palsy, we have to look carefully at this area here to see whether there is any bony erosion, whether there's any destruction of this on an axial scan. This is where we're going to look for it. And this is an axial T1. I'm very fond of axial T1 sequence, especially at skull base, because it shows us the anatomy of the uh, of the fat. You can see the clivus, and you can see the fat within the clivus, and here laterally you can see replacement of the fat by abnormal tissue which has now spread into the jugular foramen, but also into the hypoglossal canal, explaining this patient's 12th no palsy. This is another patient over here. You can see the jugular foramen with the more posteriorly, more anteriorly is the uh, hypoglossal canal, which is here. You see it better. The hypoglossal canal, it not only contains the hypoglossal nerve, it also contains a venous plexus, which communicates between the inside of the perimedullary space with the retropharyngeal plexus. But you can see in this patient, this is much more widened, and it has got a component which is inside and outside, leading towards our very favorite carotid sheath. So this is a hypoglossal canal schwannoma or hypoglossal nerve schwannoma. Uh, and again, to re-emphasize, to look at the T1, these are various sequences. Whilst you can just about see the abnormality on the STIR sequence, on T1 weighted sequence, it's much more easier. On STIR, you can see the soft tissue abnormality, but sometimes it can be a little bit trickier, especially at the skull base. So please review the T1 weighted sequence if you're suspecting marrow abnormality or bone invasion from tumors. So we have come out of the hypoglossal canal, and then our favorite location is within the carotid sheath. The 9th, 10th, 11th nerves are slightly anterior, whilst the 12th nerve is a little bit posteriorly located, close to the posterior belly of the digastric muscle, and at the level of the mouth, it's going to go then swing anteriorly. But right here in the carotid sheath, it's vulnerable to another disease, and this is a patient who's got right-sided palsy. You can see the carotid artery flow wide very well over here. The white line over here is the wall of the artery, whilst here you can see this is the flow void within the carotid artery, and the wall is expanded. It's hyperintense. It's kind of crescentic. So this is a dissection with hematoma within the wall of the artery, intramural hemorrhage. This is a carotid artery dissection, much nicely shown on this MR angiogram over here. Normal appearances of the left internal carotid artery from the cervical course into the petrous course into the cavernous portion, whilst here in the distal cervical course beneath the skull base, there is irregularity of the artery. There is narrowing of the lumen because of this dissection. And what this dissection does, it causes actually compression of the hypoglossal nerve, and it is thought to cause compressive ischemia of the hypoglossal nerve, which can cause the hypoglossal palsy, and of course it can result in Horner syndrome as well. The final bit of the hypoglossal nerve, so we have seen how it comes out from the brainstem through the cisternal portion, through the hypoglossal canal, and now outside the hypoglossal canal within the carotid sheath, and finally it has to reach the tongue, and it does so at the level of the hyoid bone. It enters the tongue from its posterior aspect, and when it does that, it's got a very specific location. I won't show too much of this neck anatomy. I know we have got mainly neuro physicians over here. It lies in a very specific plane, which is deep to the mylohyoid muscle and superficial to the hyoglossus muscle. So these are the intrinsic muscles of the tongue, and it's got a very specific location between the two. So we have got the hyoglossus more medially, which is here, and then the mylohyoid, which is much more laterally, and it's located in that space over there. And it supplies the intrinsic as well as the extrinsic muscles of the tongue. Uh, And just a final slide really to show that not only tumors of the skull base can cause hypoglossal palsy, but also tumors of the tongue in themselves can invade. So this is a squamous cell carcinoma which has invaded laterally into the hypoglossal nerve and will result in paresis of the nerve more distally. So this is a tumor which has invaded into the nerve and has resulted in the palsy of the nerve. I think that's all I had to share with you today. And fortunately, we are actually for change. Uh, we have finished on time or just before time. Uh, just a couple of things I wanted to say to you is, especially in regards to discussion of this cranial nerve anatomy, is what I wanted to share was how our understanding has evolved. Initially it was about the extracranial, extracerebral appearances of these cranial nerves, right from the dissections by Da Vinci or Paget, and then it evolved as the understanding evolved of the cranial nerve nuclei, and hence the emphasis on understanding the anatomy, the location of the cranial nerve nuclei of these nerves, and this has become much more relevant, especially with increasing use of immunohistochemistry of these nerves and of the brainstem as well. And somewhere along the line, I also wanted to share with you the phylogeny of some of these nerves as to how it has evolved with our evolution from the ancient animals, well, not ancient animals, ancient times to current times, especially along the olfaction of the trigeminal and the facial nerve. So it was kind of this sort of a global overview of cranial nerve anatomy, but not looking just at the nerves, but also understanding the concepts of the nuclei and the function that they subserve. So thank you, friends. I think that's all I have to say today. I'll take any questions if you have any. We got any questions for me? Anyone?
If anyone has a question, you can unmute yourself and
Okay, I think there are no questions, so I think we'll stop there. Uh, it's I'm finding it difficult to do it for next weekend, but I'll try and reschedule it sometime during the week. I know we are already one session behind, but I've got some commitments for next weekend, so I apologize in advance, please. But I will make up for it. So thank you, friends, and enjoy your Sunday.
thank you, Dr. Herwadkar.
Thank you.